was extended from the entrance of the ear canal, where we are now, and you know we're at the entrance because of all the cilia, the hairs. So the outer third of the ear canal is where the hair follicles are located. And this wax extends all the way to the ear canal, so through the bony part of the ear canal, which is the inner 2/3, to the eardrum, which is approximately in its entirety about 3 centimeters in length. The consistency of the earwax is quite soft. It's almost like a clay type of consistency. This type of wax can be quite tricky to vacuum at times because it can block the tube, the Zollner suction probe. So what I'm trying to do here, I'm just trying to release the wax. The wax is also attached to the ear canal via skin adhesions. These skin adhesions act as double-sided sticky tape. They stick to the underside of the earwax but also to the surface of the ear canal. And what I'm trying to do here is just release some of this dead skin keratin. You can see the tail of keratin there pulling and stretching from the Zollner suction probe. We're working posteriorly, so at the back of the ear canal, there we are, you've got a better view there. So I've decided just to use the Jobson's horn now, so I'm just sliding the Jobson horn to the roof of the ear canal. Again, we are quite lateral still, you can see all the cilia, all the hair, so we know we're on the outer third. Just trying to get the Jobson horn inwards. Because we are on the cartilage portion of the ear canal, we're able to safely insert the Jobson horn against the cartilage, against the ear canal wall, because the cartilage portion of the ear canal is semi-sensitive, so we can apply some pressure, and it's also quite flexible, whereas the inner 2/3 of the ear canal is made up of a very thin lining of skin, almost 0.1 millimeters in thickness, directly on bone, and that's very sensitive if you come in contact with the bony part of the ear canal. The cartilage portion of the ear canal, you've got some muscle that sits on top of the cartilage and also some fatty tissue, and the skin that lines the cartilage portion of the ear canal is a lot thicker, it's about 1 millimeter in thickness. So the Jobson horn, I did manage to remove a section of the earwax, but because the wax is quite soft, the Jobson horn almost squashed the soft earwax like butter and spreading it at the base of the ear canal. So I've just tried to go back in with the Zollner suction probe here. You can see we've got a couple of chunks of wax out. I know some folks don't like the hairs, it obscures the view, and I appreciate that, but there's no clinical need for me to remove the hairs. Whenever you perform a clinical procedure, you never do more than it's necessary, because if I try and cut these hairs and something happens, and then my insurance companies won't be happy and the patient won't be happy, and the hairs, they're not affecting me perform the procedure. They can do in certain cases. I have got an interesting case that I will upload during next week sometime, where it was literally a forest of hairs inside the ear, and I will upload that. And I did end up removing a lot of the hairs in that procedure, but this one, it wasn't affecting me, so I just continued. And with the follicles, if you cut the follicles, they're just the hairs. The follicles are just going to grow another layer of cilia, another layer of hair. Sometimes they can grow back thicker, and also the hairs actually serve a purpose. They are involved in the filtration, so they trap dust or dirt that enter the ear. The hairs also allow for a substance called sebum to be secreted. So hair follicles, especially on the scalp, they're attached to sebaceous glands, and these sebaceous glands secrete an oily lipid substance full of alcohols, cholesterol, squalene, long chains of fatty acids, saturated, unsaturated chains of acids, and the sebum provides coats the ear canal, and it provides a film of protection against bacteria or fungus penetrating deep within the ear canal outer layer of skin. And by cutting these cilia, these hairs, you're not going to get this sebum substance being secreted by the sebaceous glands that then help protect the ear canal. This sebum secretion is also slightly acidic in pH, and the acidity also helps repel insects from entering the ear, and it also inhibits certain bacterial and fungal growth. So we put some olive oil into the ear just to soften this wax, as it was blocking the Zollner suction tube, and the wax wasn't coming out in big pieces. It was very sticky and tearing off in little pieces. So just put some olive oil, just soak the ear, and you can see it's a bit blurry in there, so I went towards the eardrum, realised it's a bit blurry, so I just decided to suction a bit more olive oil out and then go back in. So this piece of wax, it's impacted directly on the eardrum, so we have to be very gentle, and it's also embedded within the inferior recess. So the ear canal, near the eardrum, about ½ centimetre away, the ear canal narrows and widens, and we call that region an isthmus. And when it widens, it creates cavities and crevices and trenches and recesses where wax can get stuck. So we've got wax that's lodged in the inferior recess. The inferior is the bottom part of the eardrum, bottom part of the ear canal. So if you're looking at a compass south, and also the anterior recess. So the anterior recess in the left ear is, if you're comparing it to a compass, to the west, and you get wax that lodges in there. So just trying to take this off the eardrum. Just getting a suction grip there, and I'm trying to lift up, and you'll see it's a bit, because there's oil in there, it does obscure the view now and again, so we just have to come out, wipe the lens. There we are. So I've just managed to remove the plug of wax from the inferior recess, and it's just got trapped at the entrance and just wriggling that through. I can see the majority of the eardrum now. There's just some wax in the attic region of the eardrum and in the anterior recess. I've just attached a fine end gauge. I'm just approaching the eardrum now, just being very careful not to make contact with the anterior bony part of the ear canal, because that's very sensitive. We don't want to rub or abrade that. Just managed to get a piece of wax that detached from the main mass of wax that's stuck in the attic. Just going back in. The patient has got a slightly retracted eardrum. When we go back in again, you'll see the top part of the eardrum where the hammer bone is. There's a little pocket, slightly retracted. The membrane is stretched around the top bone, the lateral process of the malleus. It's stretched around it. So that means the eardrum slightly sucked in, what we call retracted due to eustachian tube dysfunction. There's negative middle ear pressure behind the eardrum, the middle ear, and that's likely to be due to a blocked eustachian tube. So the eustachian tube is a narrow orifice that connects the middle ear to the back of the nose and the nasal pharynx, and that regulates the air pressure. We want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere, and that's where the eardrum is most mobile. There's a bit of staining of wax because it was stuck to the eardrum in the centre part of the eardrum. That was more staining as opposed to a piece of wax. We just left that. It wasn't going to cause any problems to the patient. I hope you enjoyed that video, guys.